So today we'll start with like all the pharmacotherapy, like antipsychotics, antidepressants, and all those. So these are like kind of very high yield, like the side effects and the or like how they are acting and what are the extra effects. So we will try to cover all those today. So basically, the for the antipsychotics, there are basically four pathways in the brain where they are acting, and they have like different mechanism of action. So because of these four pathways, they have their effects, and then they have like side effects. So here they have written the pathways. So usually we are not going into all pathologies and everything, but for this antipsychotic meds, I think it is important to know like their mechanism of action and all those kind of stuff. So basically, there are four pathways: mesolimbic, mesocortical, nigrostriatal, and then tubulo-infundibular. So, in the U world, there is very nice picture, so we can just go through it quickly. So, this is basically the brain, and then these are the four pathways where the antipsychotics are actually working, right? So, this one is mesocortical pathway, the yellow one, and then mesolimbic pathway is the blue one, and then nigrostriatal, and then tubulo-infundibular. So we will see what are their effects and what are the side effects. So they usually in the question stem they are usually asking like this sort of stuff indirectly. So we will see it. So for the mesolimbic, the all the antipsychotic effect, like the blockage of dopamine and then the effect of blockage of dopamine, antipsychotic efficacy, they are basically affected in mesolimbic pathway. And all the extrapyramidal symptoms, like all the like the acute dystonia, akathisia, and Parkinsonism, like all these ones are basically due to nigrostriatal pathway effect, like because of antipsychotic medications effect on nigrostriatal pathway. So then we have the EPS system. And then this one, tubulo-infundibular pathway, is the hyperprolactinemia. So sometimes they just give in the question stem like the patient was having some antipsychotic for such a period of time, and then he have like gynecomastia or like nipple discharge or something like that. So that is basically the side effect of the antipsychotic on the tubulo-infundibular pathway. So these are basically the four pathways that we have to remember. Um, and then I was just looking this chart. So this is like helpful to explain it. So basically this dopamine pathways and their antipsychotic effects. So this one is the mesocortical one, the this one. So the flat effect, the like there are positive and negative symptoms. So the flat effect is because of mesocortical. Then mesolimbic, as we have seen, it is basically the antipsychotics, like the antipsychotic effect is the mesolimbic one. So it is important to remember they are affecting in the mesolimbic. And then the EPS system, all the movement system, dystonia, akathisia, Parkinsonism, and tardive dyskinesia. We will study all these like in detail later on, but for now, the all these symptoms are because of antipsychotic effect on nigrostriatal pathway. So this one. And then the last one, tubulo-infundibular pathway, is basically hypothalamus and pituitary. Like we don't have to like I think remember these all structures, but at least it's good to know the pathway and what are the effects. So hyperprolactinemia, that side effect is basically on tubulo-infundibular pathway. So this is just the kind of basic. And now the antipsychotic, they are also called neuroleptics, and the mesolimbic is affects our emotion, reward, associated pathology, all this, and mesocortical cognition, executive function. Low dopamine cause negative symptoms of schizophrenia, like the flat effect that we see is due to mesocortical, so negative symptoms. And the nigrostriatal is basically movement. Low dopamine causes EPS system. All the movement disorders are nigrostriatal. And then tubuloinfundibular prolactin hormone, hyperprolactinemia. So low dopamine is the main effect of the antipsychotics, but the side effect are these. So the antipsychotics are also called neuroleptics. Overall mechanism D2 activity, like blockage of the dopamine, and primarily indicated for psychotic symptoms, schizophrenia, related disorders, depressive. So they are like used in so many different disorders. And then onset is acute, rapid, calming effect, and decrease in agitation, antipsychotic effect. So there is no reason to combine two or more antipsychotics, though it is a quite common in clinical practice because they are saying like all are equally effective. So all are equally effective except clozapine. So clozapine is the one that is very high efficacy, considered to be most effective in treatment resistant schizophrenia. So this one is given in the uh, treatment treatment resistant, right? So atypical antipsychotics second generation are as effective as typical first generation, but what is the main difference? Side effect. Antipsychotic but are thought to have better adverse effect profiles. Main difference is low risk of EPS and tardive dyskinesia, but more metabolic side effects. So what is the main difference in the first generation and second generation antipsychotics? The first generation causes more EPS, extrapyramidal, the movement disorders, and the second generation, they have less EPS, but they are more like metabolic effects and all those. So choose a drug to which the patient has responded in past or that was used successfully in a family member. So this is important. So route is usually PO, short acting, long acting, IM on injections for acute agitations. All these are available. And if there is no response 4 to 6 weeks, then we switch the drugs. And then minimum 6 months and usually for life in most patients with primary psychotic disorders, variable for other indications. So minimum is 6 months, but if it is recurrent or other disorders are present, then it is like continue for life kind of. So what are the Canadian guidelines for the treatment of acute psychosis in emergency settings? So haloperidol is the drug of choice, plus minus lorazepam, and then loxapine, lorazepam, olanzapine, oral quick dissolve. Its time to peak is the same as regular PO, and then risperidone. It is present, like these are the forms. So these are basically the uh, medications for the acute settings. And now this one is the first generation and the A versus atypical, that is the second generation. So this one block D2 receptor and this one D2 plus serotonin receptor on presynaptic dopaminergic. So this is the main difference. And then this is inexpensive injectable form and EPS less prevalent. So the most important one to remember in the first and second, I think it is the less EPS in for with the second one, second generation. And then cons EPS more prevalent, including tardive dyskinesia syndrome in long term, not mood stabilizing. And this one is expensive. And the main side effects are the metabolic side effects that are the weight gain, hyperglycemia, and all the metabolic disorders. So basically, that is the antipsychotic. And then these are just the typical ones are haloperidol and all these, but these are just the doses and the maintenance. Um, and then the second generation one that have the metabolic profile, like metabolic side effect, risperidone. So these are the available forms. Then this one, palperidone, olanzapine, and ziprasidone and all this. So basically we are using the drugs according to their side effects and the different profile, right? So the QT prolongation is important adverse effect of all antipsychotics. Although not required, consider getting ECG prior to and after initiating new medication and to monitor QT. So all the antipsychotics prolong the QT, so it's a good idea to have the ECG before, but it is not like mandatory according to the patient's condition. And what are the typical ones? Chlorpromazine and haloperidol warrant systemic baseline and follow-up ECG. And from the atypical, the ziprasidone has the highest risk among atypicals, and clozapine also warrants systemic baseline and follow-up ECG. So in the atypicals ones, these two are the important to have the ECG profile, and then in the typical one, the chlorpromazine. And then the features of neuroleptic malignant syndrome is FARM, that is fever, autonomic changes, and rigidity and mental status changes. So the neuroleptic malignant syndrome, these are the features, and then the rigidity is like important here. And then farm symptoms are also seen in serotonin symptom, and it can be distinguished from NMS by the following. So what is the difference between NMS and serotonin syndrome? This is twitching, shivering, restless here, and severe global rigidity. So the rigidity is like the important to distinguish, I think, from the serotonin one. Flushed and sweaty and pallor, and also here basically there are GI symptom in serotonin, vomiting, diarrhea, and abdominal pain, and in the neuroleptic malignant syndrome there is no GI symptoms. So this is I think the distinguishing point between these two. And then what are the common use of atypical antipsychotics? That is the second generation one. So the risperidone, as we know, like the second generation have the lower EPS profile, so low incidence of EPS than the typical ones, and then associated with less weight gain compared to clozapine and olanzapine. So in the second generation one, the medication that cause most weight gain and the metabolic effect are the clozapine and olanzapine. And then what are the disadvantages? Highest risk of EPS among SGAs, avoid if high risk of EPS are existing, and the sexual they can cause like the elevated prolactin, sexual dysfunction, and all these. And then olanzapine is the well tolerated and low incidence of EPS, but the disadvantages is olanzapine and clozapine causes the highest weight gain and metabolic effects. So this one weight gain and metabolic effects, and clozapine also weight gain and metabolic effects. So avoid in diabetes because of this side effect. And then sedating, avoid if high risk of falls. So olanzapine is like sedating, so it should be used with cautious, especially in elderly population because of the falls and fracture. And then quetiapine, slightly less weight gain compared to clozapine and olanzapine, but more than the other atypicals. So the highest one was the clozapine and olanzapine, and then quetiapine. And then this one is the avoid if sedating orthostatic hypotension, avoid if high risk for falls or fracture and QT prolongation in high doses, cautious if cardiac causes. So this cardiac risk. So this one is also sedating, so avoid in like falls and fracture risk. And then this clozapine is the treatment resistant, like if nothing works, then this is the last option. Treatment resistant schizophrenia does not worsen tardive symptoms, may treat them. And then approximately 50% of patients benefit, especially paranoid patients with and those with onset after 20 years. So this one is important to remember. This is treatment resistant schizophrenia. And as we have studied, like they cause this highest weight gain and metabolic effects, olanzapine and clozapine. And this one is also sedating, avoid if high risk. So all they are like sedating. And potentially severe constipation, avoid if the risk of fecal impaction or bowel perforation. And cardiomyopathy, cautious if existing heart disease, reduce seizures threshold. So cautious if seizure disorder. So this is like the very risky medication. So in the cardiac patient and like seizure patients, use with caution. And the main side effect, agranulocytosis, avoid in existing leukopenia, neutropenia, require ongoing CBC monitoring. So because of its effect of agranulocytosis, the CBC monitoring, a regular CBC monitoring is very important with clozapine. And the weekly blood counts for 6 months. So after initiating the therapy, there should be weekly blood count for 6 months, then every 2 weeks. So first weekly, then every 2 weeks. Do not use with other drugs that may cause bone marrow suppression due to risk of agranulocytosis. So the first 6 months, the weekly monitoring, and then after 6 months, every 2 weeks. And then the last one is aripiprazole, less weight gain and risk of metabolic syndrome compared to olanzapine, and lower incidence of EPS compared to haloperidol. And this is also mood stabilizing, and insomnia and akathisia is the side effect of this one. So what are the, like they have mentioned, it's like in what are the side effects here, like different, but these are like the side effects that are common with all the antipsychotics. So they are mostly they are anticholinergic, dry mouth, urinary retention, constipation. So all the effects of anticholinergic, alpha adrenergic blockade, orthostatic hypotension, erectile dysfunction, failure to ejaculate. That's why they are causing like the orthostatic hypotension. And then dopamine blockage, extrapyramidal syndrome, sorry, galactoria, amenorrhea, erectile dysfunction. So because of dopamine blockage, all these side effects. And sedation, weight gain, hematological agranulocytosis, that is the most important with clozapine. And then hypersensitivity reactions can be present, like liver and blood dyscrasias and all that. And then neuroleptic malignant syndrome, and endocrine metabolic syndrome, and cardiac QT prolongation. So the side effects of the antipsychotics are very important, and also the individual, like which one is more in which drug. So the neuroleptic malignant syndrome is psychiatric emergency, and then because of the strong dopamine blockade, there is increased incidence with high potency and depot antipsychotics. And then the risk factors, medication factors, sudden increase in dose, or starting a new drug. And the patient factors, medical illness, dehydration, exhaustion. So all these, there is like acute psychiatric emergency, neuroleptic malignant syndrome. So what are the clinical features? There's tetrad, mental status changes, usually first, then fever, rigidity, autonomic instability, and 24 to 72 hours. And labs, there are increased in creatinine, phosphokinase, leukocytosis, and myoglobinuria. So the treatment is supportive, discontinue. The first in the first thing in management is discontinue antipsychotic, and then provide all the supportive treatment like hydration, cooling blankets, and dantrolene. And then the medication is bromocriptine, that is dopamine agonist. And then mortality is 5%. So for the neuroleptic malignant syndrome, usually in the case they are giving like a patient like discharged from the hospital, or maybe like he's taking antipsychotic for a long time, and then uh, like he just developed like fever and all the clinical features like rigidity and all that. So then they give like all the conditions like serotonin, or other like malignant hyperthermia or neuroleptic malignant syndrome. So the main clue is like the patient was having antipsychotic and he have like fever, rigidity, and these symptoms. And also sometimes they mention like creatine phosphokinase is raised. So these two three clues are directing toward neuroleptic malignant syndrome. So the EPS, that are the side effect of the antipsychotics. So what are those? So those are basically acute, that is the dystonia, akathisia, parkinsonism, and dyskinesia, that is tardive dyskinesia. So the dystonia is like acute or tardive. And then the acute, and it is young Asian and black males more. And then the presentation is like sudden posture, abnormal posture, torsion, twisting, muscle groups, and like ogrogyric crisis, laryngospasm, or torticollis. So there is like a sudden spasm. So and it will be acute. So they will mention like the patient was taking antipsychotic and all of a sudden there is like a spasm in like the neck muscle or like the eye muscle or something like that. And then this onset is within 5 days, and the tardive is more than 90 days. So this one, tardive dyskinesia, is like the after, usually like after a long period of time. And then the treatment here is benzoprine or diphenhydramine, and usually intramuscular. And then this akathisia is usually present in older females. Motor restlessness, crawling sensation in legs relieved by walking, very distressing, increased risk of suicide, and poor adherence. So there is like motor restlessness. Patient cannot like sit still or in a calm way. So that is and also have crawling sensation. And this happens within 10 days. And then the acute treatment is lorazepam, propranolol, and benzoprine. or diphenhydramine. And best approach is to reduce the dose or change the antipsychotics to low potency, because that is the main cause. And then in Parkinsonism, it is also acute. It's like Parkinsonism like features are present, like tremor, rigidity, cogwheel, akinesia, and all these. And then it is within 30 days. So this is within 5 days, within 10 days, within 30 days, and then this is more than 90 days. So this is like kind of in a later onset. And here also the treatment is benzoprine, and also reduce the dose or change it to different atypical, like the second generation one. And then this one is like purposeless, involuntary, constant movement that involve facial and mouth, less commonly the limbs, rarely the diaphragm, like the hiccups. So all the involuntary movements are present in dyskinesia. And then it is no good treatment. May try clozapine, like it was mentioned. Maybe it can be given in tardive dyskinesia, and then discontinue the drug and reduce the dosage. That is like the first line management in all of these. And then there is like a FDA approved drug, valbenazine, that can be used in tardive dyskinesia. So these three have almost the same drug treatment, but this one is like valbenazine is a one that is used in dyskinesia. So the anticholinergic agents type, these are benzoprine and diphenhydramine that are used here, and do not routinely prescribe with antipsychotics. Give anticholinergic agents only if high risk of acute EPS or if acute EPS develop. Okay, if there is high risk or there is like actual it develops, then it can be given. And do not give these for tardive syndromes, because they worsens the condition. So these medications are not given in the tardive one, but they can be used here. So these are basically the extrapyramidal side effects of the antipsychotics, and all the uh, I think you will also have some of the good charts, so we will see if we can see some of those. So the management of psychosis, the one that we studied, the second generation, these are the drugs, and the first generation antipsychotics may be used, but they usually have high EPS syndrome, sorry, high EPS side effects. And then, yeah, these are just, I think we have studied there already, like D2 receptor blocker, and the second generation are the D2 and the serotonin antagonism, and it has more metabolic effect, and this one has more EPS effects. And then, yeah, so this is in the first generation, they are divided to low potency and high potency. So the low potency basically are the chlorpromazine and thyroidazine, and then the high potency neurological is the haloperidol. So the high potency, the haloperidol, it has more EPS side effect. And the first one, non-neurological, has orthostatic and anticholinergic and all those histamine effects. So so this is the same that we studied there. Acute dystonia, we are giving benzoprine, and this is sudden and acute. So they will mention in the question stem like the patient have like sudden contraction of the neck or something like that. So that is acute. Akathisia, the patient is not sitting and very restless. So the management is beta blocker benzodiazepines, or like propranolol can be given. Parkinsonism, it is also benzoprine and amantadine, and in the tardive they are giving the um, clozapine, and the other one that was written there was the venbelazine, I think. So this is just the drug-induced Parkinsonism that is caused by antipsychotics or antiemetics, and there is like prominent rigidity and bradykinesia, tremor, mass facies, like as in Parkinson's. And what is the management? The first thing is decrease or discontinue the drug, and then anticholinergic, benzoprine or diphenhydramine can be given. So this is just the tardive dyskinesia, switch to clozapine, antipsychotic is required. So we have already seen it there. So these are the metabolic effects of second generation. So basically they are weight gain, all the metabolic side effects, right? Highest risk is clozapine or olanzapine, and then the lowest risk is ariprazole and ziprasidine. And monitoring guidelines, we have to monitor the body mass index and baseline and monthly, and then fasting glucose, fasting lipid panel, blood pressure, waist circumference, because of all the metabolic effect, right? So this is basically the monitoring guidelines. And clozapine treatment guidelines is treatment resistant schizophrenia associated with suicide, and the adverse effects are agranulocytosis. That's why we are monitoring the CBC, and then seizures, myocarditis, and metabolic syndrome. So these are the so this is just the treatment of acute mania. The second generation antipsychotics are given. First generation antipsychotic haloperidol can be given, lithium, valproate. So lithium is avoided in renal disease and valproate is avoided in liver disease. And then carbamazepine, and then the combination can be given. And then the benzodiazepines as the adjunctive. So mood stabilizers in bipolar disorders. So the first drug of choice is lithium, and that is usually given in manic and depressive features. So, and the main side effects are diabetes insipidus, hypothyroidism, tremors, and Epstein anomaly. So it is teratogenic, so it is like not given usually in pregnancy, and these are the side effects. And for the valproate, hepatotoxic, so we are not giving in liver disease, and neural tube defects, and carbamazepine is also manic features, so these are the side effects. Aplastic anemia, SIADH, and neural tube defects. So these all are like teratogenic, lithium, valproate, and carbamazepine. And then lamotrigine is depressive features. So lamotrigine causes the benign rash and Steven-Johnson syndrome. So the side effects I think is like important. And then the lithium indication, mania due to bipolar disorder, contraindication, chronic kidney disease, heart disease, hyponatremia, because like it is not given in these conditions. And then the baseline, blood urea nitrogen, creatinine, calcium, and urine analysis. And then thyroid function test, because it causes the hypothyroidism, and ECG because of coronary risk factors. So these are all the side effects. Acutely, it is tremors, ataxia, weakness, polyuria, polydipsia, vomiting, diarrhea. So basically GI symptoms, and these tremors are important. And then the chronic nephrogenic diabetes, thyroid dysfunction, and hyperparathyroidism. So basically these are the